Hey, good evening, everyone. How are you doing today, wherever you are? I see Barbara is already on, Thelma is already on, saying hello. Good evening to you. We want to thank you all for joining us this evening. We have an awesome presentation for you as usual. Let's bring up our slideshow. We're going to start off with our slideshow tonight. So the reason why we do greetings is because we want to make sure that we are hospitable. So if you are on tonight, don't be shy. Just introduce yourself. Let us know where you are watching from, and so we can also acknowledge you for being here. And as always, I like to show our guest our hospitality. So Dr. Robert Lewis from Mission is watching us tonight. Robert, welcome to you. Thank you so much. By the way, he was our first, very first presenter. So we want to thank you for joining us on this evening. We have Mission in the house again. Yes. Martha Thomas from Austin. Good to have you. Remember, you can chat right below on your mobile device. Okay, if you're on your cell phone, if you're on your tablet, right below here is the chat box. You can just make sure you put your comments there. Get familiar with it if you're new, so that way when it's question and answer time, you can go ahead and ask your questions. I want you all to greet our guests tonight as well. Others on here, I see Raul, I see Donna, Josie, Patty, Robert, Loida, Don Daniel is on tonight. Greetings to you, sir. Thelma Alvarado, McAllen, Texas, in the house. Loida is all the way from Canada, Toronto. Welcome to you. I think Dr. Fisher speaks French, so maybe she can greet you in French. Dr. Donna Cooper is on. Dr. Cooper was also one of our guest presenters. She talked about how to manage stress. So we thank you, Dr. Cooper, for joining us on this evening as well. Okay, good. We're just gonna get into it. Again, if you come on, please go ahead and introduce yourself in the chat. Let us know that you are here, that you are watching. And as I introduce our guest, I want to see all the love pouring in, okay? I want to see all the love pouring in. So let's get to it. Welcome to, this is presentation number 7 out of what? 10 presentations. So that means we have 2 more to go after tonight's presentation. So this is our 5-week masterclass of secrets of mental and emotional wellness. Raul from San Antonio is in the house. Raul, good to have you tonight as well. So again, we really want to thank you for journeying with us. You could have been in many places, so we don't take your time for granted. That's why we also like to give you a shout out, give you a little greetings, because we know that you can be anywhere, but you chose to be here learning some wonderful things with us. So we really truly appreciate it. Okay, by now you know this slide, but we go through it just for the sake of if there are any new folks. My name is Chance, U.S. Navy veteran, #1 best-selling author, also a minister, and I am the host of this series where we bring on experts to share with students and regular people as well who may be on, so that we can learn how to up level in different areas of our life, be it spiritual, physical, financial, emotional. It does not matter. We want you to do well in your career. We want you to do well in your chosen field. So we bring on different experts. We examine different books, all these different things, bringing you relevant content and information for professionals, for anyone who has a success-minded orientation. So you are in the right place. Every Thursday we are on at 7 p.m. rather, but we chose 7:30 and also Mondays for the sake of our students. We are putting these presentations on for from the University of Southern Indiana nursing program and nurse practitioners. So welcome to you. And because of you, you are helping us to learn as well. So we get to learn by osmosis all the wonderful things that you all are learning as well. So we really appreciate this teamwork in being able to help you, and we help ourselves by learning also. So it's a win-win situation. And we've covered so many topics. Tonight is one that we have not covered. We're going to be talking about depression and suicide, but our other presenters have shared with us several things. We spoke about resiliency, coping, disaster and trauma, addiction recovery. We still need to go a little bit deeper into that. And so hopefully on Monday we can tackle that in a little more detail. And basically, all in all, we want you to not only be well, but stay well. We want to teach you different strategies for taking your health seriously and for making it the best that it can absolutely be. So again, after this presentation, we have just 2 more to go, but we ask that you finish out with us on next Thursday. So Monday we're gonna go, okay, for presentation number, what is that? We got 3 more to go actually, right? So Monday, then Thursday, and then we're gonna give you just 1 more, so that that one is gonna be more like a celebration kind of a thing, a recapping of everything, and where for the last one, we are going to actually make it where we're going to give you how to achieve greatness and to do well as a high performer. So we're going to give you high performance strategies. So that's not one of the regular presentation. I'm saving that for last. Yours truly, myself, will give you that presentation where we are going to talk about, again, how do you, achieve greatness in your career, in your finances, in your health. We're going to give you some power pack strategies in that final presentation so we can wrap it all together. So do make sure you stay with us to the end. We greatly, greatly appreciate it. So this is the drill. I'm going to introduce our guest. Then she is going to give us a presentation, lecture style. And then we're going to ask some questions together. I'll interview her, pull out a few questions from the presentation, but then you are free to ask also any questions that you want to ask, and Dr. Fisher will do that. Alrighty. So before I introduce her, let me see who else is in the house. Josie is here. She says, "Good evening, everyone." Good evening, right back to you, Josie. Good to have you with us on tonight's presentation. So, Dr. Fisher, Dr. Judith B. Fisher. Judith Bernard Fisher is a licensed clinical psychologist serving as clinical faculty in the Graduate Department of Psychology and Counseling and director of the Andrews University Counseling and Testing Center in Barron Springs, Michigan. She also maintains a limited private practice in the community where she helps individuals achieve emotional healing. That's what I'm talking about. That's the kind of stuff we love here. She also holds a master's degree in linguistics and a doctorate in counseling psychology. She also completed a clinical psychology training at Mercy Hospital in Detroit, Michigan, and her training also included predoctoral internship and postdoctoral fellowships at the University of Notre Dame, where she functioned as staff psychologist at the university's counseling center. Now, here are some other areas where she specializes in, and that's why tonight you are going to be getting someone who really and truly not only knows what she's talking about, but will help you in your practice, help you with your patients to really, help them with this thing. Because all of us, in some way, shape, or form, have to deal with bouts of depression from, here and there. And I would like her to clarify some of the things, because in many circles, I serve a faith-based community, and even that is a taboo. So we're looking forward to her presentation so that we can address some of these taboos as well. But anyways, her personal and professional life journey has taken her through several countries, classrooms, and impacting the lives of thousands of young people and adults. She is an educator, counselor, administrator, motivational speaker, writer, parent, and also mentor. Dr. Bernard Fisher has a strong commitment to helping men and women to realize their true potentials. Her areas of clinical expertise includes depression, anxiety, eating disorders, self-esteem, career issues, and she also enjoys couple and group therapy. She is fluent also in Spanish and French. Hey, we are in the Valley here, so this is a Hispanic community primarily. We do have quite a few Spanish-speaking folks on, so if you want to greet us, feel free to do so as well. Dr. Cooper on here is fluent in Spanish also, so you're in good company. So we really thank you. You're one of us now. We give you a virtual hug. So let us all welcome, without further ado, Dr. Judith B. Fisher. Please, in the comments right now, I want you to say welcome, Dr. Fisher, or some form of greetings. Let's pour out some love and show her that we appreciate her time for being with us tonight. Dr. Fisher, I turn it over to you. You can begin turning the slides, and anything else you want to share with your bio, feel free to do so.
Good evening. It certainly is a pleasure and an honor to be with you this evening. And I understand that you've been participating in quite a few different timely presentations, and I am hoping that this evening's presentation will be very helpful to each one of you. Now, I'm hoping that you can hear me at this time.
Yes, we can hear you. We're hearing you good.
Wonderful, wonderful. Well, I was asked to speak about a topic that is really dear to my heart, a topic that is very important for all of us, especially during this COVID-19 time, a topic that has become quite a concern here in the US. As a matter of fact, we're talking about pandemics, but just not too long ago, recently, depression was referred to as an epidemic here in this country. So this evening, it is certainly important for us to take some time to literally explore what that entails. And this evening, we'll talk about the growing epidemic of depression, and we'll discuss risk and treatment approaches. Now, the past few weeks and months, and I really thank Pastor Chance for the opportunity to be here with you this evening as well. I enjoy my work here at Andrews, and on behalf of our Andrews Counseling and Testing Center and community, we are glad to be here, and we want to greet each one of you. Right, so let's get started a little bit, because over the past few weeks and months, there have been revolutionary changes in our lives as we've grappled with the impact of our current pandemic. And we've considered its long-term effects on every dimension of our lives. Researchers remind us that a century ago, the world faced similar circumstances as countries around the world fought what was referred to as the Spanish flu, as you may know. The numbers of infected during the 3 waves of the pandemic at that time, which lasted roughly between 1918 and 1920, hovered around 500 million. And about 50 million, we're told, died of conditions related to the flu. Although the overwhelming focus was on the medical, social, and economic impact of this pandemic, millions paid a very high mental health cost as they attempted to manage life through and beyond the Spanish flu. Norwegian researcher and professor Stephen Erik Mamelon from the Oslo University College of Applied Sciences noted that the number of first-time hospitalized patients in the 1920s and beyond with mental health disorders attributed to influenza increased by an average annual factor of 7.2 in the 6 years following the pandemic. In addition, he pointed out that Spanish flu survivors reported sleep disturbances, depression, mental distraction, dizziness, and difficulties coping at work. He also postulated that influenza death rates in the US during the years 1918 to 1920 significantly and positively related to suicide. Now let's come right to where we are in 2020. During our current COVID-19 crisis, sleep disturbances, mental distraction, and difficulties coping with not only work changes, but also with the many life changes we currently experience have been reported by many. Now, pandemics such as the 1918 Spanish flu and our 2020 COVID-19 create a cesspool of negative emotions that have the potential of compromising our mental health, leading to overwhelming levels of pathology and emotional turmoil. Emotions that are usually observed during those chaotic moments include fear, anger, confusion, guilt, shame, intense feelings of alienation and abandonment, excessive worry, feelings of helplessness and hopelessness, and definitely there's grief. Many of those emotions are usually present also in a diagnosis of depressed mood or anxiety, and when those emotions are intensified, they may increase the risk of suicide. Frontline health workers or professionals who personally experience human desperation and loss during those moments of uncertainty and intense pain as they care for their patients, they're not immune to such sentiments. With many of those from earlier pandemics noting that they were haunted by a sense of frustration and grief, not just at the time of the pandemic, but even years later. Let's take a much closer look at the implications of depression. According to a recent World Health Organization, there's a global report that they've written. It's entitled Depression and Other Common Mental Disorders Global Health Estimates. Depression is a very common condition with about 300 million people affected worldwide. This number is purported to be about 3.4% of the world population, with depression affecting those of the younger generation as well as those of the older generation and a great number of women. If you look at the slide, you'll notice that the rate of depression and anxiety for women happens to be almost twice as that of men. Risk factors for depression also include low socioeconomic status, unemployment, relationship break, physical illness, life events, especially the loss of a loved one, and problems related to alcohol and drug use. Depression is determined by the World Health Organization to be the greatest contributor to global disability and the leading factor in suicide, which most recently has been at about 800,000 worldwide a year. Globally, the total estimated number of people living with depression has increased by about 18.4% from 2005 to 2015. And as we said a few minutes ago, depression is more common among females, about 5.1%, than males at about 3.6%. And globally, it's ranked as the single largest contributor to non-fatal health loss. Worldwide, depression rates are falling in some countries, such as Canada, China, Germany, Russia. But you notice, as in the slide, that the lines that the Russian rate of depression is much, much more extensive than that of the US. But if we look at the very bottom, you'll notice that the rates are increasing from 2000 to 2012. This is worldwide. We're going to take a look at what's happening here in the US, and we'll focus on the US. According to the Center for Disease Control, depression affects about 18 million people in this country. Data from the National Health and Nutrition Examination Survey states that over the past few years, 8.1% of American adults aged 20 and above had depression in any given 2-week period. Again, with women with a rate of about 10.4% compared to men at about 5.5%. The National Institute of Mental Health, another large organization, has also done its surveys on a yearly basis, stated that there's about 17.3 million adults in the US with at least one major depressive disorder. And this number represents about 7.1% of all US adults. Again, with the major depressive episodes, adult females are coming at 8.7% compared to males at about 5.3%. The prevalence of major depressive episode was also highest among adults reporting 2 or more races. Now, 1.9 million children are also diagnosed with depression every year, so it's not just the adults. And although 80% of individuals seeking treatment have symptom reduction within a few weeks, very few seek treatment. Depression results from a complex interaction of social, psychological, and biological factors. Depending on the number and severity of symptoms, the depressive episode can be categorized as mild, moderate, or severe. It can also appear as a low-grade, persistent condition, or it can be superimposed with a major depressive episode. Also, it can be a part of a more complex illness, such as bipolar disorder. Now, when we refer to the term depression from a clinical perspective, we're referring to a condition beyond a state of sadness. Now, we all experience at times sad moments in our lives due to life circumstances. We may feel some degree of apathy and our energy may be drained momentarily. But quite often, after engaging in an energy-producing or mood-enhancing activity, we get back to our regular selves. Sadness and grief are normal human emotions, and those feelings are not necessarily indicative of a depressed state. The loss of a loved one can also result in grief responses that may suggest depressed mood, but typically grief feelings evolve through the grief process, allowing people to return to an emotionally stable place within a reasonable time frame. Individuals challenged with depressed mood do not bounce back so quickly. At the very least, there is a period of debilitating sadness lasting several weeks, most of the times interfering with life functioning. Several criteria must be met before a diagnosis of depressive mood is made, and if left untreated, the condition may intensify, leading to potentially more significant symptoms, including suicidal risk. Now, how do we know when someone is depressed or when someone is just having the blues? Now, here are a few things that we want to be aware of. Typically, there will be changes in feelings, such as a melancholic mood, loss of interest or pleasure in all or nearly all activities. Sometimes a person may have a feeling of hopelessness or worthlessness, feelings of excessive or inappropriate guilt, irritability, anxiety. There will also be feelings or changes in physical health. Now let's take a look at what that entails. Changes in appetite. There may be significant weight loss or weight gain when not trying to diet. Of course, definitely disturbed sleep, physical agitation or slowness, fatigue, loss of energy. Sometimes a person may experience headaches or stomach aches or other psychosomatic symptoms. Now, these are changes in the physical being. There can also be changes in behavior, excessive crying, social withdrawal, neglect of personal hygiene, indecisiveness, not being able to concentrate, recurrent thoughts of death or suicide, ideation, or gesture of any kind. These are changes in behavior. Also, there will be some safety risk changes that you may observe as well. Expressions of hopelessness, powerlessness, worthlessness. Sometimes a person may give away important possessions as though they no longer need them or care for them. There may sometimes be some self-destructive behavior such as cutting or pinching or doing other types of things to the body. There can be violent threats against other people. For example, you may have noticed of or heard of a number of instances when individuals who end up in schools and school shootings quite often would think about killing other people and then killing themselves. So there may be some violent threats against others and against self, out of control behaviors. These are some general things that you can look for when someone is really having something other than the blues, and it may be more of a depressive episode. Among college students, we're having some of the same concerns. Levels of anxiety are rising as early as 5-year-olds. Students in 6th or 7th grade, sometimes in 5th or 4th grades, are experiencing high levels of anxiety. There are also feelings of loneliness and suicide. If you look at those slides, you'll notice that from 2008 to 2017, the numbers have increased significantly, even with the suicidal rates. Factors contributing to increased suicide risk include the presence of mood disorders, anxiety, substance use disorders, severe neuropsychiatric disorders, head injury, aggression, hopelessness, a history of childhood abuse, adverse life events, psychosocial stressors. These are some of the number of things that we assess for when we're looking at risk for suicide. The frequency of major depressive disorder continues to increase. We're talking about 50% more within the past 10-year span. Here's some more risk factors that the National Institute of Mental Health has generated. And I'm just going to go through a few of those. Per suicide attempt, those increases the risk of another suicide. Substance use disorder, family violence, including physical or sexual abuse, unemployment, being incarcerated, being bullied at school. And over the past years, we've noticed quite a few of those were students that were bullied at school or people who were bullied at work experience suicidal ideation and sometimes would complete a suicide. Social isolation is another one. Over the past few months, we've talked about social distancing, and a lot of people are feeling isolated. And as a result of that, the risk for suicide increases with those isolations. Medical illnesses, being exposed to other suicidal behavior, or being between the ages of 15 and 24, or over the age of 60. So these are, again, suicidal risk behaviors that we're looking for. According to the Centers for Disease Control, men are more likely to die by suicide than women, about 3.5 times more. But women are more likely to attempt suicide, about 2.5 times more. Men are more likely to use more lethal methods, such as firearms or suffocation, while women are more likely than men to attempt suicide by poisoning. Based on the 2017 National Survey of Drug Use and Mental Health, it's estimated that about 0.6% of the adults aged 18 or older made at least one suicide attempt. And this translates into approximately 1.4 million adults. Also, per the CDC, certain demographic subgroups are at higher risk. For example, American Indian, Alaska Native youth, middle-aged persons have the highest rate of suicide, followed by non-Hispanic, white middle-aged, and older adult males. African Americans were a little bit lower, but these days, these past years, it tends to have, those numbers are coming up a little bit more, while Hispanics continue to be the second lowest rate. Now, there's an exception. African American children under the age of 12 seem to have a higher rate of suicide than white children. Again, a lot of factors come into play, such as socioeconomic, and we'll talk a little bit more about that later. While younger preteens and teens have a lower rate of suicide than older adolescents, there has been a significant rise in the suicide rate among youth ages 10 to 14. Suicide ranks as the second leading cause of death for this age group, accounting for about 425 deaths per year, and surpassing the death rate for traffic accidents, which is the most common cause of death for young people. 60% of children and adolescents with depression are not getting any type of treatment. About 90% of all people who commit suicide meet the diagnostic criteria for one or more of the psychiatric disorders. People who abuse alcohol and or drugs or are dependent on them, attempting suicide nearly 6 times more often than people who do not abuse these substances. Now, the CDC puts out on a yearly basis 10 leading causes of death. And if you look right here, the 2013, among young people ages 10 to 14, it was the third leading cause of death. For the other age groups, about the second leading cause, and you notice it's right there in green. Now, this is 2013. Let's take a look at 2015. The numbers remain pretty much the same. At least the third leading cause of death, second leading cause of death, all the way to 34. But let's take a look at what's happened recently in 2018. You notice that the young people ages 10 to 14, it has moved up from the third leading cause of death to the second leading cause of death. According to the CDC, suicide was responsible for more than 48,000 deaths in 2018, resulting in about one death every 11 minutes. Every year, many more people think about or attempt suicide than die by suicide. In 2018, 10.7 million American adults seriously thought about suicide. 3.3 million made a plan, and 1.1 million attempted suicide. As most public health problems, suicide is preventable. 2017, 47,000 people died from suicide, one death every 11 minutes. This is something to think about. Firearms account for 51% of the suicides. When countries reduce access to means of death, suicide rates declined. England, people once could end their lives with carbon monoxide. And then when the country switched to less toxic gas for heating and cooking, death from suicide dropped by 40%. Bridge barriers also keep people from jumping from off a bridge, and that also reduces the rate. In the US, more than half, as we said a minute ago, half of all the suicide deaths are the results of firearm. And there's evidence that when access to gun goes down, so do suicide deaths. Now let's take a look at preventative measures, because this is where we can begin to help most significantly. Depression has been identified as a major contributing factor to disability diagnosis in the US, and even in adolescents, it's considered by many to be among the most serious forms of psychopathology. And many empirical studies suggest that self-esteem and parental influence may be strong predicting factors in childhood and adolescent depression. Self-esteem, parental influence. So parents out there, you have something you can do. Prevention initiatives and treatment programs are most effective as these factors are explored. In 2017, the CDC developed a document. It's referred to as a technical package entitled Preventing Suicide, a technical package of policy, programs, and practices. It is a comprehensive treatment approach to suicide prevention, identifying 7 strategies and elaborating on approaches to strengthen these strategies in the fight against suicide. If you notice, we can start with the first strategy. We'll go through a few of those. The first one is to strengthen economic supports, helping people to develop financial stability, because quite often when people feel helpless and hopeless and they can't find themselves economically sound, there is less meaning to life and thus increased suicidal risk. The second one, strengthen access and delivery of suicide care, making sure that people have access to care, to mental health professionals, reduce the provider shortages in underserved areas, safer suicidal care through system change. These are things that will help to increase the mental health of individuals, and especially in underserved communities, and to reduce the risk of suicide. Another one is to create protective environments, making sure that access to lethal means among people of risk is no longer available, and that there are policies and organizational changes and cultures that promote healthy living. Another one, and this one is one that I spend a lot of time on, and this is promoting connectedness. We were created to live in nurturing communities. And when people feel isolated, when people feel that they're no longer part of a community, there is less of a need to be alive. And for a number of people, this takes them over the edge. So when communities put together peer norming programs and community engagement activities, and they help people to become more connected, that is in essence helping to prevent suicide. Another strategy that the CDC talked about is the teaching of coping and problem-solving skills, helping people to learn how to solve problems, and parenting skills and family relationship programs. All of these things help to strengthen communities. Also, identifying and supporting people at risk, gatekeeper programs. As a matter of fact, for a number of individuals in the community, having clinical or mental health first aid types of training, understanding what it is like when someone is depressed. What are the signs of suicide? How can one help? How can one refer? So looking at suicide as a community concern as opposed to an individual concern definitely is a preventative measure. And the last one that the CDC talks about is lessen harm and prevention future risk, which is after suicide, what happens? You may have heard on many occasions where if at a high school, a student goes and completes a suicide, a number of other students may also be at greater risk. And so having post-prevention programming certainly helps to reduce the risk of suicide. Now, when we consider approaches to care and healing, in addition to prevention initiatives, attention must be placed on interventions, also referred to as secondary prevention and tertiary, or as we mentioned a couple seconds ago, postventions. So we're going to shift our attention at this time to empirically based treatments for depressive episodes. And I'll just mention a couple of those. How is depression treated? Let's take a look at effective treatment modalities. Now, there is a plethora of treatment modalities that have yielded a spectrum of results when working with depressive patients. Healthcare providers often offer one of the most researched and acknowledged ones. Now, in addition to psychotherapy, we do know that medication is a very strong part of the treatment for depression. Medication management, antidepressant medications such as SSRIs and tricyclic antidepressants referred to as TCAs. And TCAs are an older set of medication that also affects brain chemistry. But SSRIs have become very commonly used for depressive episodes. SSRIs treat depression by increasing levels of serotonin in the brain. Serotonin is one of the chemical messengers. It's a neurotransmitter, and it carries signals between brain nerve cells. And so the SSRIs block the reabsorption or the reuptake of serotonin into neurons. And this makes more serotonin available to improve transmission of messages between neurons. SSRIs are called selective because they mainly affect serotonin, not other neurotransmitters. Now, the Food and Drug Administration, the FDA, has approved quite a number of SSRIs to treat depression, and you may be familiar with some of these names. Celexa is one of those, Lexapro, Prozac, and Paxil, and Zoloft. And sometimes antipsychotic medication can also be prescribed if there's some evidence that the depressive mood may be part of a bipolar and other psychotic presentations. Some of the medication that you may be familiar with are Abilify, for example, or Zyprexa. And these are usually prescribed when there is a mixture of maybe some psychotic features with the depressed mood. Now, the efficacy of SSRIs in improving symptoms in persons with major depressive episode is well established, particularly for individuals with moderate to severe pre-treatment illness severity. However, for those with mild depressive symptoms, especially children, adolescents, and young adults, effective treatment emphasizes psychosocial interventions as opposed to medication and lifestyle changes such as exercise, sleep, nutrition, and assessment for drug use. Now, back in October of 2004, the FDA required a so-called black box warning for antidepressant drugs of any class, and that warning became effective January of 2005. And in 2006, the FDA warning extended to young adults aged up to 25 years. And typically, it is to remind those who are prescribing that young adults may be more at risk of suicide at the beginning or when they are taking prescribed medication. So there has to be some monitoring of individuals as they are taking the prescription. Now, therapeutic objectives of acute treatment are safety, response to therapy, patient psychoeducation, and symptomatic and functional recovery. Effective treatment for depression includes an integration of a multimodal approach with emphasis on positive mental health, resiliency, identity establishment, cognitive reframing, and pharmacotherapy. Now, psychotherapeutic approaches include interpersonal psychotherapy, and that's one of the approaches that's uses, and it literally focuses on relationship, identifying problems, then how individuals interact, and helping them to regain their balance. Now, a more common approach is CBT, and most of you are familiar with that. The CBT model includes the thoughts, emotions, and behaviors. And there is a cycle where one leads to the other, and so on. Cognitive behavior therapy focuses on thought processes, emotion, and behavioral responses. This approach helps people to develop alternative ways of thinking and behaving, which aims to reduce their psychological distress. Often referred to as a father of cognitive behavioral therapy, Aaron Beck pioneered this form of psychotherapy, and it revolutionized the fields of psychology and psychiatry. Now, in treating depression, it's important to consider all of the person's dimensions. I find a holistic approach to be most meaningful. As we considered earlier in the discussion on prevention, depression presents within a context, and attending to every dimension of that context yields the greatest reward. So, when helping people challenged with a depressed mood, it helps to identify default thought processes that send strong messages of defeat, inadequacy, and low resilience to the individual. And as automatic self-defeating thought processes surface, one of the goals is to increase awareness of those defeating thoughts and help recreate healthier thought processes that contribute to rebuilding the self, strengthening sense of worth, reconstructing resilience, and facilitating the shifting from an automatic negative set of lenses to a more positive and realistic, optimistic, and hopeful set of lenses. CBT facilitates identifying unhealthy thought processes that impact the emotions and subsequently the behavior. So it's a rebuilding process, focusing on the interplay among thoughts, emotions, and behavior. Many health or mental health professionals are most qualified to provide this treatment. Another very common approach, and this is more recent, is positive psychology. And this one focuses on the strength of individuals, signature strengths. You may have heard of approaches that include gratitude, staying in the moment, self-compassion, using meditation, prayer, random acts of kindness. And all of these are part of positive psychology. Now, this one focuses on empirical study of positive emotions. It is strengths-based, as I mentioned a few minutes ago. And this approach has been championed by a psychologist named Martin Seligman. He mentioned that treatment models usually focus on what's not working. For example, in mental health, the focus has been on analyzing mental disorders and human suffering and attempting to change that. So Seligman's intent was not to replace the traditional approach, but to build a more complete picture of human experience by flipping the coin and focusing on what makes people happy, what makes people fulfilled, what makes people emotionally sound. Since its inception, positive psychology has brought on lots of research in a variety of areas such as happiness, optimism, self-esteem, well-being, motivation, hope, resilience, mindfulness, and positive thinking. Resilience is one of those traits that I work with my clients quite a bit, adapting in adversity, bouncing back. When we think of COVID-19 and everything that's going on, resilience definitely is a trait that can be nurtured and developed. Focusing on those positive elements seem to also promote healing and restoration. Just imagine a young adult who grew up in a negative environment where the focus has mostly been on his or her failures and deficits. As the focus shifts to that person's strengths, indicators of resilience and worth, there is going to be greater motivation in that person to change and embrace hope, optimism, feelings of self-confidence, and achievement. That shift in itself will positively impact the mood. For those of you who are not mental health providers or coaches, you can still work amazing transformation in pointing out people's strengths and affirming the good in them constantly. Everyone has strengths, and everyone has some level of resilience. The more those are acknowledged and celebrated, the stronger they grow. An area of emphasis is gratitude and its powerful impact on the mood. Vitamin G, as some call it, is the subject of a number of studies that do show that when people are expressing gratitude, especially early in the morning or during the day or on a daily basis, their mental health is improved meaningfully. Being thankful, showing gratitude. So the benefits of gratitude are in different levels. Gratitude has psychological benefits, physiological benefits, social benefit, greater empathy, stronger relationships, a stronger immune system. All of these are parts of what we refer to as positive psychology. In my integrative treatment model, effective interventions include identifying thought processes and establish neural pathways that sustain the depressive mood and a sense of learned helplessness, building resiliency through a progression of strength-based interventions, and exploring strategies to enhance optimism, problem solving, motivation, self-affirmation, and the belief that the human system has the capacity to adapt, change, and become whatever we envision it to be. Also, helping people to embrace a spirit of gratitude helps develop healthier neural pathways. Effective treatment for depression also includes exploring our physical, spiritual, and social dimensions. For people from mild to moderate depression, physical activity is essential. An exercise protocol as simple as 15 to 30 minutes several times weekly, adequate sleep, emphasis on good nutrition, hydration, access to sunlight, and trust in a God or higher power who is most powerful and compassionate are all essential components of an effective treatment approach for depression. The chart that you're seeing is the New Start acronym. And again, the focus here is on nutrition, exercise, water, sunlight, temperance, air, rest, and trust. Now, for those living in colder climates where sunshine becomes scarce during the winter months, they may be challenged with seasonal affective disorder, SAD, a type of depression that most often exacerbates or is exacerbated by the fall and winter season with fewer days of sunshine. Exercise is essential for those with SAD, and sometimes a light box may prove helpful. Empirical studies support the treatment of mild to moderate depression with a combination of CBT strategies, the learning of life skills, and the implementation of regular exercise. Walking for a few minutes several times a week has amazing benefits, not only in our physical dimension, it helps to lower blood pressure, weight loss, pain reduction, etc., but it also helps to stabilize our mood. So when we're dealing with someone, when we are interfacing or communicating with someone who may be depressed and possibly suicidal, there are some things that I usually encourage not to do and some things that I encourage to do. Now, here are some things I usually say not to do. Don't minimize the feelings of that person or try to cheer this person up. Don't try to analyze or interpret the person's behavior or criticize or shame this person. Try not to get angry, even if you feel anger at that time when you're interacting with that person. Don't be afraid to ask if he or she is considering suicide. Quite often we have the myth that if we ask someone whether they're considering killing themselves, then we're putting this idea in their heads. And that's not the case. If it's already there, it's already there. It's helpful for you to know so that you can get them help if they do need the help. Don't dismiss or discount any suicidal threat. Don't argue with this person as to whether they should live or die. Just focus on the person's reasons for living. Don't get scared by the intensity of this person's emotion. Don't become depressed yourself. And that's why it's always good to check yourself and to make sure that you are participating in a self-care protocol. Don't leave the person alone, or don't act shocked or judgmental, and definitely don't swear to secrecy. Quite often people who are considering suicide will say, well, I don't want anybody else to know. And it is definitely not the best judgment to swear to secrecy. Here are some things that you can do to help. Do tell that person how much you care, what specific behavior changes are causing your concern. Do take time to listen. Do reinforce positive thinking and responses. Do encourage this person to engage in physical activity, even if it's just walking a few steps with you. Assess the potential for self-injury. If there are guns in the home and you have access to those, then you want to remove them. If there are other lethal means or things that may be used by this person, then you want to make sure that these things are not accessible. If the person is suicidal, there's no need to panic. Go ahead, talk about it. The person will probably be relieved to have a chance to be open about it. Do offer hope by suggesting that he or she will feel better once this person gets help. Do refer, ideally, to a mental health practitioner, and if resisted, refer to a trusted and respected figure who may in turn help this person to access more targeted help. From a spiritual perspective, I believe no matter our circumstances, we have the capacity to grow and develop skills and view of ourselves and of others within the concept of being created in the image of a healthy God. It is true that our nature plays some role in who we are, but for the most part, our nurture is a potent contributing factor. We learn most of our responses to life, and most responses that are learned can be unlearned. Also, the human system can learn new responses to stimuli at any age. Don't let anyone make you believe that you're too old to learn. Self-awareness is a critical step to change. As we examine automatic thought patterns that become foundational to created neural pathways that sustain a life of depressive mood and feelings of worthlessness, we can claim our heritage of strength and worth and reconfigure, develop, and sustain healthier thought patterns, healthier concepts of ourselves and of others. We can learn healthier habits. We can strengthen our resilience, and we can live more fulfilled lives. I'm reminded of a little book published over a century ago by a gentleman named James Allen. He was an essayist, a 19th century British writer who wrote extensively about the relationship between our thoughts and our quality of life. And he published this book entitled As a Man Thinketh. And I want to share with you a brief passage from his essay. Here's what he says. Man's mind may be likened to a garden, which may be intelligently cultivated or allowed to run wild. But whether cultivated or neglected, it must and will bring forth. If no useful seeds are put into it, then an abundance of useless weed seeds will fall therein and will continue to produce their kind. Just as a gardener cultivates his plot, keeping it free from weeds and growing the flowers and fruits which he requires, so may a man tend the garden of his mind. In essence, Ellen reminds us that we have the power to cultivate what goes on in our minds, and we have control over how we respond to life circumstances. Our automatic thoughts of fear, unrest, apprehension, panic may seem uncontrollable. We can, however, change those responses, and sometimes with assistance from professionals and a supportive network. And regardless of the circumstances, we can work on changing the thought patterns and life responses that may seem to be natural, but are truly learned reactions to the things we experience. We can certainly choose to cultivate healthier neural pathways and achieve emotional stability no matter the circumstances. In other words, we can shift from a life of depressive mood to a healthy and fulfilling life. We can remain in a healthy place no matter what goes on around us. Ellen's message takes us to my spiritual side, and from the Bible, Proverbs chapter 3, verse 7, that also refers to the same topic. It says, for as a man thinketh in his heart, so is he. The Bible passage underscores the significant value of our thoughts and our identity. This new COVID-19 pandemic is already impacting our lives extensively, and the cost to our emotional health has yet to be determined. Drastic changes in work delivery and routine like tasks such as how we shop, how we do relationships, how we worship, even how we mourn our dead, how we live, not only have significantly disrupted our current lives, but also threaten to have long-term effects. Social distancing, as we call our physical reclusion, promotes a sense of alienation and abandonment. The world is grieving. And just as during the Spanish flu pandemic of 1918, the potential emotional fallout over the next few years is very real. Our emotional health is the most important dimension of who we are. We cannot achieve health and healing without attending to our emotional selves. If at any time we become deficient emotionally, let's not become discouraged. Depression is treatable. Suicide is preventable. Healing is achievable. Reach out, seek help, cultivate resilience, learn and have the courage to embrace a health promoting lifestyle. It certainly takes courage. And believe that we can, no matter what the circumstances. We were created to thrive. We were created to adapt. We were created to be resilient. May this time of uncertainty and change become an opportunity for growth, and may this be a life-enhancing moment for all of us. Now, here are a couple of resources that may be of interest to you. These are some apps that are pretty much familiar to most of us. One of them is called the WhatsApp app, and you may find some of those helpful. There are CBT workbooks also that are available. And besides those, you have some other apps. Pacifica is another app that is very commonly used out there that some of you may be interested in. And here's some other apps that are fairly helpful. Moodlift and Mood Mission and Talkspace. And there are a couple more that I want to share with you that you may find helpful. Headspace and Happily. These are apps that are very easy to download on your phone, and they do provide you with a number of resources, even connecting with a counseling professional. And I wanted to make sure that at the very end, you have this National Suicide Prevention Lifeline, 1-800-273-8255. And this concludes this presentation. And if you have questions, then we will move on to that at this time.
Awesome. Wow. Wow. This is really and truly a powerful and needed subject. I think we can even learn some more on that. Alrighty, what I'd like you to do is at this time, if you do have questions, start posing them. I do have a few that I'd like to present to you. So let's see here. So this is our interview section. But again, start putting your questions here in the chat box below, or if you're on your computer, should be on your right-hand side. All right, Doc, you mentioned quite a bit here. I mean, honestly, this is really, I'd like you to elaborate on a few things, though. And as a reminder as well, because sometimes we, like I said, I know in my community, many times it is downplayed on suicide and depression. But you mentioned, which I also saw in Nature's magazine a few years ago, that depression itself is a global contributor and will be the leading cause of disability worldwide. Can you elaborate more on that? Because again, I don't think many people make that connection. So when we say it causes disability, how does that manifest itself? What are some of the causes? Like the chain reaction behind that?
Well, very good question. when we're looking at worldwide 300 million people dealing with depression, and when we look at the typical criteria for depression or symptoms of depression, we're considering individuals who have less energy than usual. So they're not able to attend to work. And if they do go to work, they have less capacity for concentrating. They have less capacity to problem solve. They have less capacity to remain in a healthy, stable place. So definitely we're looking at criteria that impacts the life of people. It impacts the home, it impacts communities, it impacts the workplace, it impacts the economy. And so when we're looking at disability, for example, right there in my small community of Barron Springs, Michigan, when individuals come to me with depressive mood, quite often, even if they are able to get to work, their capacity to fully function is literally reduced significantly. And so when we're looking at disability, we're looking at instances when individuals are not able to fully function. They're not able to fully carry out their responsibilities, take care of their families, take care of their jobs, take care of their communities, because they are hindered by an illness that impacts the chemistry in their brain, that an illness that literally gets them to believe that they are less than who they are, or that they are not able to manage life as they should.
Makes a whole lot of sense. Makes a whole lot of sense. And that's also another reason why we should be compassionate and understanding to people as they're dealing with some of these challenges. Another thing is now you mentioned several strategies on dealing with depression or combating depression. One of it being cognitive reframing. Elaborate more on that, and what does that look like? How can we practice that cognitive reframing?
Good.
Reframing.
That's another very good question. And cognitive reframing is one of the strategies or interventions in CBT or cognitive behavior therapy. Just as we said earlier, in cognitive behavior therapy, we're looking at the interplay among thought processes, emotions, and behavior. So the understanding is that we have negative set of automatic thoughts. For example, someone who is experiencing a depressed mood may, in the presence of a task, believe, oh, I can't do this. I'm not able, I don't have what it takes. I can't do this. And this person remains in a negative frame of mind. And when that negative frame of mind becomes the predominant or the automatic thought in your brain, then emotions will match with that thought. For example, I usually give this example. Let's say that somebody is looking at a dog, a beautiful dog. It's a nice dog, but it's running towards you. If I'm afraid of dogs, I may say, for example, oh my goodness, this dog is going to hurt me. And immediately I may start to run. I'm going to feel fear. So the thought is this dog is going to hurt me. I'm feeling fearful. That's the emotion. And my behavior is running. On the other hand, if I were to look at this dog and say, oh, this is a beautiful dog. I love dogs, and it's going to come and I'm going to pat its head and I'm going to play with this dog, I am no longer feeling fear. I am feeling good. I am feeling warm towards this dog and I'm not going to run. So cognitive reframing has to do with taking a look at the thought patterns that we over the years have learned, and we didn't learn them overnight, and literally help us to shift those thoughts, stop them, replace them with positive or realistic thoughts. And as a result of that, our emotions will pair up with those new, healthier thoughts, and our behaviors will also line up with the emotions and the healthier thoughts. So cognitive reframing is reframing, turning around, reconfiguring, changing thoughts that lead to feelings of inadequacy, that lead to fear, that lead to anxiety, that lead to depressed mood, and changing those to healthier thought processes and thought patterns.
Awesome, wonderful. Um, Now, how is that? Well, CBT seem to be close to that. How does those two work? When you reframe cognitive behavior therapy, I think changing thoughts there, is it similar or is it?
Yes. Cognitive reframing is one of several interventions within the CBT approach.
Okay.
All right, it's one of the interventions. For example, another one would be for people to take a look at the way they think and the way they do things and their behaviors. Again, cognitive behavior therapy takes a look at the thought patterns. It takes a look at your emotions, how you respond within the context of those thought patterns, and how you behave. And literally, the goal is to help you to change those to healthier thought patterns. And CBT is the overarching approach itself.
Okay, wonderful. I got two more. Well, actually three. By the way, again, if you have questions, post them in. I don't want to take up your time, but now you also mentioned the CDC. That there was a slide there with the CDC. I guess some suggestions as well. But they mentioned the first thing on there was strengthening economic support. And that is something that I participate myself sometimes in panel discussions locally relating to health and the spirituality and health. But one of the things I often mention is that you really cannot address health without addressing economics. Even in all these things, they're good, but what we see in reality is in low income communities in particular, for example, good nutrition, even though we need it, people look at the cost. And even though we know in the long term it's going to be a benefit, but yet, no one wants to go to a health food store, for example, come out with 6 items for $100 when they can go to Walmart or something, come out with 2 or 3 trays, cartons of stuff, for that same $100. So economics is really very important. And even now, especially in COVID-19, that's one of the big challenges. Of course, the economy took a hit, along with our health. So speak to that a little bit. Anybody, it doesn't matter the economic strata, because the more money we have, sometimes the greater the problems and the greater the stress load. So everyone, I think, is affected. But just speak a little bit more to that on the relationship with finances and how it impacts us, or cause or contribute to depression.
Well, yes, definitely. When we're talking about depression and suicide, we're talking about a very complex issue. It's not just economic, it's not just one factor, it's not just one thing. However, and as you mentioned a few seconds ago, it is true that people from all walks of life experience depression, regardless of how well off you are or not. However, we do realize that when individuals are placed in a position where they feel helpless and they become hopeless and they feel stuck and they're not able to move in the direction that would suggest a healthier lifestyle, then quite often that becomes a very strong factor in their becoming depressed. And so, for example, in one of the earlier slides, I showed that quite a number of countries worldwide have done specific things to reduce the numbers of suicides within their communities. And for example, in China and some other countries, there have been lots of emphasis on community policies, on community help, increasing the possibilities and the accessibility of, let's say, for example, food and basic life needs for as many people as possible. So, yes, the economic factors weigh heavily on the minds of a lot of people. We find that when people are not able to pay their bills, when they're not able to take care of their families, when they're not able to achieve a sense of stability, they literally become stuck and they feel that they have no more meaning in life. And when life loses its meaning, then for many people, it means I no longer need to live. I no longer have a stake in this world, and there's no reason for me to live. So, definitely, when we're looking at, for example, food, accessibility. Quite a number of our communities, especially in the underserved areas, have a food desert. We can't find good things. We're not able to live in ways that promote healthy living and ways that promote a feeling of dignity. And when people are not able to do that, then certainly they're more prone, they're more at risk for suicide and depressive mood. And so from a community, from a mental health, from a public health approach, if we're wanting to work more on prevention than on reactions, it certainly would make a lot of sense to take a look at the community, determine how can we help individuals in that community to feel that they indeed are worth whatever it is that you're doing for them, that they certainly have accessibility to those things and that they're able to achieve the basic things that life has to offer.
Awesome. Now, there was also a statistic that mentioned to the effect of 60% of people are not receiving treatment, or only 60% receiving treatment. What are some of the contributing causes to that?
Oh, yeah. Very good question. One of the things that I do consistently is to work on destigmatizing mental health issues. I remember years ago, even here at our university, and we have one of the most internationally populated campuses here in Berrien Springs. I remember years ago, as director of psychological and counseling services, most of the students who came to receive help were those of the majority, especially from different countries in the world. There are some of those where people would not even approach a counseling office, or they would not go to see a physician. They will go to see a physician if their arms are broken, if they need something for a physical need, but for a mental health need, definitely not, because for many cultures, the thought of mental health struggles or challenges was equated with deficits, mental deficit, or people would say, well, I'm not crazy.
You're
And
crazy.
also for individuals who, um, let's say, stated that they were Christians, for many, they thought, well, do you know what? If something is going on with my mind or I feel depressed, I need to just pray about it. What I usually tell people, if your arm is broken, you don't just pray about it. You may pray about it, but you go see someone. If you're having a heart problem, you pray about it, but you pray about it and go see a cardiologist as well. So we have different professionals that attend to different needs that we have. And definitely the stigma has been one of those. A great number of the world population, up to a few decades ago, did not believe in seeking help. If you recall, it was just a few decades ago that people who had mental health issues were locked up in our country
Yeah.
in in hospitals, and they never came out again. Families who had young children who may have presented with maybe being on the autistic spectrum, or may have had some indications of depression, were literally put away. They were ostracized, and as a result of that, even now people hesitate to come out and to get help. And so one of the things that will be helpful is to help people realize that, hey, mental health is just as important as physical health. And there's nothing that says that you have deficits or something is utterly wrong with you if you seek help for a mental health need. Being able to access
Yes.
is certainly a healthy thing, and it takes courage to do that.
And that one, I mean, we can continue hammering on that because even in the professional space, I've shared some articles, I've read some articles along with that too, even grad students, PhD students, even doctors are ashamed also to go get help because, hey, I'm a physician. And not only that, but if someone find out, I've read that some physicians even go to other states using
Mhm.
fake names, pretty much lying, and only cash basis, so there's no trace of anything. And so even there's a distrust. I know even within the clergy as well, many people don't want to go get help either because, again, even though you say, oh, self-care, they feel that maybe my next job might be in jeopardy if they say, oh, well, he or she was struggling mentally. And so we really, really need to be educated on this thing, because I see it even for people being free, spiritually as well. I think this is one of the most misunderstood area. And I know some people have all different theological views, but at the same time, as you were saying, I am for being practical. And I'm also studying about the mind as well. One of the things I realize is that many, even people of faith, they're not being victorious in their life for this very reason, because again, I just have to pray about it, or maybe I'm demon possessed, or different things like that. And those may be realities too, but at the same time, you're right. My car broke down, I go get help. You have other health problems, we go get help. But when it comes to the mind, no one really wants to deal with that. So I really, what can we do? By the way, what else can we do to destigmatize? Let's ask that. What can we
Yeah,
do to
well,
destigmatize?
that's one of the things that we do here on our campus. And again, on most university campuses nationwide, we have suicide rates that are also not the best. Every year, about 1,100 to 1,500 college young people kill themselves.
Wow.
Depression is very real on our college campuses. Anxiety is very real as well. And one of the things that we do is educate. It's educate, educate, educate. Help people to understand that it is okay, it is normal. Mental health is just part of the many dimensions of who we are. And just as we attend to every other parts of ourselves, it makes sense to attend to our brains, to our thought processes, to our capacity to remain in a stable place. And the more young people, and again, if you recall, one of the slides I showed was that we're looking at young people even as early as 10 to
Yes.
14. For them, this is the second leading cause of death.
Wow.
And
Yes.
there are young people as young as 8, 9, 10, who, because they were not treated for depression, came to a place where they felt that they no longer wanted to live. And so we're talking about, you mentioned a few minutes ago, from the religious point of view, in our churches preaching that, in our libraries mentioning that, in our schools teaching, and in our families as we work with families. For example, one of the things that other countries are doing is to literally educate the community, providing lots of mental health types of education, peer types of support, helping people to come to the point where they realize that, hey, we can talk about this. It's okay. It doesn't mean that something is utterly wrong with me. So the more we talk about it, the more we help people realize that it is a part of life. It is a normal part of who we are. Then that certainly helps to destigmatize the issue or the concerns that people have about mental health.
Awesome, awesome. And again, if you are on this broadcast this evening, and you're hearing this, please let us act on some of these things ourselves. Let's reduce the stigma. Let's talk about it. And if you do need help, go get the help. There's no shame in that. It's better to be well than to suffer unnecessarily. Many of us suffer unnecessarily because
Mhm.
we harbor these things. And we sometimes, even that is a mental cognition issue, where we think we have these perception. This is what people might think of me, which and why people are not even thinking those things, anyhow. So please take this to heart and let us do a better job in supporting one another, supporting others who are going through struggle, and make this thing become. It's just like if anybody else have any other issue. It's not worse than per se. It is just a condition, and we all need to fix every condition that we have. Josie said the mind indeed is a battleground. Yes, we have to take care of it. It's precious. Barbara says, thank you, Doc, for the information. Thank you so much. Josie also, again, thank you for the information. Barbara says, a lot to take in. Loida says, thank you for the excellent presentation on depression and suicide. Very relevant topic, especially during this pandemic. Thelma said it was very informative and interesting. I have a question from Amoy. I'm going to broadcast it here to everyone. Amoy says, good presentation, thanks. At what point do I report if an individual wants to commit suicide? Very good question.
Very good question. And that's a very good one. When it comes to reporting, um, we're talking more about getting this person help. All right. Because one of the things that usually happens when people feel suicidal is because they feel that they're alone. They feel they can't trust people. They feel that life is no longer worth it. And so whoever is attempting to help needs to do whatever he or she can to maintain that trust that this person has in them. And so you want to make sure that this person knows that you have their best interests at heart. Typically, if in your interaction with someone you realize that someone is depressed, it certainly would be helpful to begin to ask some questions. There is a very basic training that is for lay people. It's called QPR. It is question, persuade, and refer. Literally, it's questioning. Hey, what's going on? How, what is wrong? What are the concerns that you have? Where are things for you? And then persuade this person to get help. And we're talking about, if necessary, walking with this person to the hospital, to the ER if needs be, taking them with you, or getting them help and referring them to a mental health professional. Now, if at one point in time, the person that you're trying to help, for one reason or another, refuses the help and says, well, no, I don't want to get help. I don't need help. I am okay. And you know very well that this person is feeling that certain way and may have access to, let's say, means of carrying out a suicide or to have an attempt. And usually when it comes to suicide, and sometimes it doesn't follow through, there's usually a thought. We call that a suicide ideation. Then there may be a plan. The plan is not quite yet, but it's a thought, then it's a plan. If the person has a plan, this means they're closer to trying or having an attempt. So if this person no longer is willing to cooperate, you want to make sure that you don't leave them alone. And if it comes to the point where they're not cooperating with you, the next thing is to try to get somebody else to come in and to join you. If you are alone with a person, you say, well, I care for you to the point where I don't want to leave you alone, and I'm going to call someone. So if you have your phone, you can call, and it's best to call another trusted friend. All right. However, if this person, let's say, is in a room and the person has access to a lethal weapon, and you're not trained to go in there and to take it away from them, then definitely you would want to call the authorities or the police, because they would have that training. And then they would, of course, bring the medical personnel as well. However, if this person is in a place where they're still willing to talk, they're still willing to listen to you, then you may want to determine whether just with you, whether they're willing to go get help, or if you need to call someone else that they may trust, whether it is a friend or a family member or a trusted pastor or a trusted teacher or someone of that nature, and then you can go along. However, if it gets to a place where your safety is compromised, then you want to go and call 911 or the authorities to come in and to help, or someone who has the experience and come in and help this person.
For the legal, from a legal perspective, for the professionals, let's say we have whatever the professional is, nurses, nurse practitioners, clergy, anyone else, you're in your role. Are there legal ramifications for not reporting?
No, there are not legal ramifications for not reporting, because when it comes to suicide or suicide attempt or a completed suicide, it's not just a result of one thing. It's really a complex thing. And there are times when you can try a whole number of things and the person still commits suicide. So it's not necessarily somebody's fault. For example, in my profession as a clinical psychologist, if, for example, someone that I'm treating is suicidal, I will put together a safety plan. I will put together a plan that helps this person to stay safe. And if I feel that this person is not capable following the treatment plan or the safety plan, I'll certainly make sure that they are hospitalized. Now, for someone who is not directly treating someone who may be suicidal, whether it's a nurse practitioner or a physician, or for that matter, an educator who may be interacting with this person, there is no legal thing that says you have to call the police. What it is that you want to make sure this person is safe. If the person is not safe alone, then you want to get someone else involved. And if that person is not in any way cooperating with you, then definitely you will call the authorities so that they can come in and they can either do a wellness check, or they can come in and help this person to end up to literally move towards a hospital or hospitalization.
Awesome, awesome. All right, I think those are all of our questions. If you have any more, post them. But again, I want to encourage you, if you do want more information, you can reach out to Dr. Judith Fisher at jfisher@andrews.edu. That's all contact information. Any presentations or anything else that you would like her to do, to speak, invited to whatever you have going on, do reach out to her as well. She was gracious as we reached out to her, and so we are so thankful. Doc, any closing remarks, any closing words you'd like to impart to
Well,
us?
yes, definitely. It has been a pleasure to share with you. This is one of the many topics that I enjoy talking about. And the reason is because on the flip side of depression is a healthy lifestyle, living the way that we were intended to live, happy and able to achieve and able to fulfill our dreams and able to be in nurturing relationships. And it certainly is important to understand what is it that we can do to get to that point. So my challenge to each one of you who is listening to this conversation that we're having will be to take a look at yourselves and become a lot more aware of the fact that depression impacts a great number of people, not just in this country, but worldwide, especially during this COVID-19 time. It certainly is helpful to be aware. It certainly is helpful to understand. It certainly is helpful to work towards destigmatizing issues relating to mental health. And it certainly is helpful to remember that we were created to thrive. We were created to be healthy and to live in with all of our capacities, and to be able to live fulfilled lives. And I certainly believe that no matter how old we are, no matter what the circumstances, because, for example, I may say very quickly that some people who've experienced abuse in the past feel that they cannot come to a place where they can live a healthy life. And that is certainly not the case. Regardless of what happened in your lives, early on or during your adult years, there is always the possibility to work towards living a healthy life no matter what. And I believe that keeping that hope is definitely one of the things that will enable us to live healthy and to live a fulfilling life. Thank you.
Awesome. Thank you. Well, Doc, again, thank you so much for making the time out to be here with us. Again, my friends, this presentation, it continues. So this is presentation number 7. We will be doing 10 in total. So we just have about one more week to go. So I do encourage you to join us again. We'll be back on Monday at 7:30. Then we take it up again on Thursday next week at 7:30. So again, for you, those of you who, if this is your first time, you can go to strategicsecrets.com/weekly webinar and get the information. That's the link where you can, invite someone. If by chance you have registered, because there's 2 different links, sometimes some people join straight directly to the live broadcast. But if you signed up, if you registered, if you put in your email for this presentation, you will be automatically sent a reminder with the link to the replay. So the replay is only available for 24 hours, but you will get the notification and then you can all watch it. Alrighty. So we thank you. And again, good night to everyone. Josie says, thank you, Dr. Fisher. Melissa says, thank you very much. I have worked 3 years with my daughter with depression. Okay. Martha said, very good information. Thank you for your time. Luther Charles says, wonderful presentation. That was great and wonderful. So you are greatly appreciated. Thank you so much.
It's been a pleasure. God bless.
Alrighty. Good night, everybody. We see you. Enjoy your weekend. We see you on Monday.